Hello, everyone. This is Rami Ahmad. I'm attending physician in internal medicine department at Yale New Haven Hospital in New Haven, Connecticut. And also I'm the chair of the educational committee at the Palestinian American Medical Association, well known as PAMA. PAMA is a non-profit organization that mainly has a mission to promote health care and health education in Palestine and in the Arab world. It's mainly run by American trained physician who's practicing here in the US with long experience. This is our third lecture actually about COVID since the outbreak started back in December. And as a mission with PAMA to kind of like to promote the health education with all this, ongoing conflict about evidence and practice in regards to COVID-19. We wanted to do this lecture with a panel of a group of experts who are like being involved in the Infectious Disease Association of America to give us more and talk about the latest evidence and guidelines about the prevention, management, and diagnosis of COVID-19. Please welcome, I would like to welcome Dr. Rebecca Morgan, Dr. A. Black-Yetter, and Dr. Reeb Mustafa, and Dr. Shahinaz Sultan. Thank you all for joining the webinar, and it's a pleasure for us to have you here. For the audiences, we're going to have at the end of the lecture, we're going to have almost 15 to 20 minutes session for question and discussion. As a timeline, we're going to start with Dr. Rebecca Morgan, who is assistant professor at McMaster University, Department of Health Research Methods, Evidence and Impact in Hamilton, Ontario, and an adjunct professor at Case Western University School of Medicine in Cleveland, Ohio. She has extensive experience leading and teaching systemic review and guideline development for national and international organizations, such as the U.S. Center of Disease Control and Prevention and the World Health Organization. Dr. Rebecca Morgan, thank you for joining us, and you can start sharing your slide. I'm just gonna give you the permission to do that in a minute.
Great, thank you. As soon as I have permission, I will.
Yeah, go ahead.
Wow. Excellent. Okay, so thank you so much for letting us speak tonight. We really appreciate it. This has been a huge effort over the past month, and that's really a culmination of so many years of research and work in guideline development from everybody on the panel tonight. So I'm just going to start off with a brief introduction of kind of decision making really in this time. I just have a few minutes, so I wanted to focus in on what do we do when we're in emergent situations, and then cover a few fundamentals of GRADE. Certainly this isn't meant to be the most comprehensive presentation, but I'll provide some resources that that you can certainly look at as well. So no financial disclosures, really everything that you just mentioned and introduced me with for my disclosures. So in the next few minutes, I'm going to talk about some strategies to facilitate guideline development in emergent situations. I'll go through our standard guideline development process, addressing really our fundamentals, so actionable questions, our quality of evidence, how we move from that evidence to recommendation, and then making recommendations. And you'll see I repeated actionable twice because that's what our goal is. And then specific considerations, certainly when time and resources are limited. So in response to health emergencies, and I'm sure I don't need to belabor that in our current climate, practitioners, decision makers, patients, everybody is really in need of these evidence-based recommendations to direct their implementation. And this could be in the hospital, this could be in the community. I've used this slide before and was able to update it today. I think we're all familiar with this picture, our coronavirus. So when responding to our health questions of urgency, full guidelines are always the gold standard that we seek. However, when we're looking at providing a response in a number of hours or weeks or even a few months, we may require a modified approach. However, I do want to highlight that the fundamental principles really remain, even in a modified approach. So we must base our guidelines on a systematic review, a rapid review, even of the literature, must make our decision-making transparent, and be very clear when reporting on the quality of evidence and the strength of recommendations. So this all comes from, again, these standards that we consider when we create guidelines, whether abbreviated or full. We have these 8 pillars that we base them off. This came out of a 2011 report from the National Academies of Medicine, Institute of Medicine at the time. And this is really that every guideline should be held accountable in these 8 ways: to establish transparency, to manage conflict of interest, to have a variable guideline development group composition. We're basing our guidelines off of systematic reviews. We have methods, standardized methods for rating the strength of recommendation. We're clear and transparent with what our recommendation is saying, goes through an external review, public comment, and then we have a plan to update. Here is what the guideline process looks like. And I think it's a busy slide really to underscore how much is going on in the process. So if we think about standard guidelines, we're looking at, at least a year-long process for full guidelines. And throughout that year-long, 2-year-long, some of us have certainly been involved with longer. We're developing our groups. We have our oversight committee, our guideline group, our members. We figure out how are the stakeholders involved, what are our working groups like, who are our actual guideline panels and panelists. We go through a conflict of interest stage, and then we start to work through the planning. So we figure out what is our priority for the guideline, who's our target audience, what are the topics that we're focusing on. We generate our questions using our population intervention comparator outcome formulation, very classic grade. We search the evidence based on our questions, consider the information. From that, we're able to judge the quality, develop the recommendations. We have very standard wording for the recommendations. We go through our external reporting and peer review process, and then have plans for dissemination and implementation. And updating. Okay, so we have this large process, and I just wanted you to keep it in the back of your minds as we go through this, not only my presentation, but also my colleagues' presentations. How do we take all of this and fit it into, a 2-week process or a 4-week process? It's quite a lot. So getting to the fundamentals, I'm going to spend the next few slides telling you a bit about grade, and perhaps this is a refresher. But within grade, when we look at the quality of the evidence, so we're focusing on, the result of our systematic review. We've captured, all of the evidence that we think is eligible to inform our research question, our PICO question, and we want to determine how confident are we in what the evidence is giving us, in that summary estimate of the treatment effect. And is that adequate enough? How adequate is it to support a particular recommendation? And we think this adequacy, or really this certainty that we have in the evidence, exists along a continuum, but we've tried to place it, I guess, divide it into 4 categories. So we may have high certainty, moderate, low, or very low certainty. The way we determine that is we look at 5 domains that may lower our certainty about the evidence. So we may have concerns about our study limitations, so risk of bias. We may have concerns if the studies aren't all telling us the same thing. We may also have concerns if they're not directly answering our research question of interest. We may have concerns if we can't tell if, there's within the realm of possibility, there could be multiple outcomes. And then at last, we may have concerns if we aren't seeing the full body of evidence that may exist. What we take from this, and if you're reading kind of left to right on the slide, we start kind of classic grade. We have randomized trials starting at high certainty because they have that prognostic balance in them. As I mentioned, the certainty can be lowered based on risk of bias or heterogeneity, inconsistency, the indirectness, imprecision, publication bias. And then we would determine the overall certainty in our evidence. With non-randomized studies, which may be of interest to you in your general research, and certainly with the topics that we're covering today, classically it starts as low certainty because we do not have that randomization component. We may still consider rating it down due to concerns for any of the domains that I've gone through, or we may actually have higher certainty in that evidence should it show a large effect or dose response. And then lastly, again, we would use that to determine our overall certainty in the evidence or across the body of evidence for each outcome. So the way we conceptualize that, as I mentioned, we have this kind of continuum of which our certainty lies. If we have high certainty about the evidence for a particular outcome, we're very confident that the true effect lies close to that estimate. If we have moderate certainty, then we're moderately confident in the estimate of effect. The true effect is likely to be close, but it could possibly be different. Then with low certainty, our confidence in the estimate is limited. And the risk there is that the true effect may be substantially different from the estimates of effect. And lastly, we could have very low certainty in the evidence or very little confidence in the estimate of effect. As we go from evidence to recommendations, I do want to point out, in case you are not familiar yet with GRADE, is we come from a very study design kind of hierarchical approach to guidelines, right? So other systems will go out, search for RCTs and say, okay, we have RCTs. They must be, high-level recommendations, strong recommendations. We have non-randomized studies. Those must be lower or lesser. And it doesn't involve looking at those study limitations or looking across the body of evidence to see, whereas within GRADE, we're taking not only the body of evidence, we're also looking at these other components of decision making to help us determine what is the recommendation, what is the decision that we're making, that action. And so in addition to the quality of evidence, we're also looking at the balance between benefits and harms, resource use, patients' values and preferences. And the way that we do that with our guideline panel is we're really weighing these. So we're saying, okay, what are the benefits and the harms? How do they weigh? Is one overwhelmingly outweighing the other? And similarly with resource use and patients' values and preference. So one of the last things I'll mention about GRADE, because I think you'll hear a lot of it in subsequent presentations, is that we're very specific about the wording of the recommendations. It's very intentional wording. So we want to portray that the strength of the recommendation, and then also the direction. So the strength, either strong or weak, or we use the word conditional instead of weak. We avoid saying we do not recommend. Instead, we try to very clearly say what we recommend against. And then lastly, going back to our PICO question, will always include the comparator in the recommendation. So the implications of what this means, so for a strong recommendation, for your population, most people would want the recommended course of action, and only a small proportion would not. For healthcare workers, most people should receive this, and for policymakers, it can be adapted as a policy. So it has these large implications on the society, not only on the patient and the practice, but also on the society, and potentially influencing insurance or coverage. For a conditional recommendation, you still have the majority of the people in the situation wanting the recommended course of action, but many would choose not to, or would not. Healthcare workers, you're involved with more of a shared decision-making process with your patients. And then policymakers, there's a need for additional debate. Okay, how do we do this in situations of urgency or emergency? So I'm not going to get into this in great detail, but I will mention that that busy graphic at the beginning of my presentation of the entire guideline process came from a collaboration between the Guideline International Network and McMaster University when they developed their first guideline development checklist. Since then, we've looked at this checklist and considered what would be the modifications were we to make rapid recommendations. And this was done in a series of 3 projects. We had a scoping review to inform this. We also conducted interviews and did a qualitative analysis and had this iterative development for this rapid recommendation extension. It contains 21 unique considerations if you are developing a rapid recommendation across the checklist items. And the goal is to streamline and expedite the process without, again, losing those fundamentals, the transparency, the standardization of it. So I pulled out a few of the unique principles to consider, because they were things that I felt facilitated the process when we were developing guidelines. So a lot of what can facilitate the process is really thinking about the organization and the management at the start. So working with the organization to understand, what are the expectations of time? What are the operating procedures that can be put into place? Can we establish expectations of meetings in advance and have a plan that we're following? In addition, I think there's this expectation of understanding that the scope needs to be reasonable if you're answering it within a couple weeks. So your PICO questions should be limited. Your outcome prioritization and outcomes identified should be limited as well. In the panel meetings, it helps to finalize the wording so that everybody can see that, be on the same page. And then setting up the peer review process and external review in advance allows people to have a placeholder in their schedule so they know this is when the document's coming in, this is how much time I have to review it and send it back. So really, in summary, and as I said, I would be brief, there are these situations, beyond coronavirus that necessitate the development of guidelines in response to different health emergencies, environmental emergencies, public health, etc. But even when produced in a short time frame, the standards remain that we base these on a systematic review or rapid review. We assess the evidence, we consider our decision-making factors, and we're very transparent with the presentation. Strategies exist, and then pointing to really that rapid checklist should you want to learn more. And then just a little teaser, I think, for the presentations to come. And what I liked was all of these guidelines, they've all come out within the last month, have been time-stamped, except for the first ones. Actually, I added the timestamp to it. But you can see how rapidly this series of 3 guidelines came out. And that's really because we had the standards in place and we're able to apply those to really facilitate a overall very smooth process for this product. Thank you very much.
Thank you, Dr. Rebecca Morgan. Well, that was like really insightful about the process of putting all the evidence in a guideline. I'm sure like you guys been on tremendous work to put these guidelines in a very short of time, giving them out of exploding, I guess, evidence or like articles and research has been published on COVID-19 since the outbreak began back in December. I think I will I'll leave the questions if there's like any at the end of the webinar, unless there's like anyone is. I think there's a question from Dr. Majdi Hamarshe. He's saying, how did external politics affect your decision about the guidelines?
External politics as in other associations or government politics? Health system. And I'm happy if we want to do questions at the end as well.
Yeah, I believe if I want to, interpret his question that he means like probably any government or any official, agencies and putting any pressure. Yeah, he means government, exactly.
Sure. So these guidelines, as you know, were developed for a professional society, so not a government society, but a professional society, and we really fell under the auspices of their board of directors. So we weren't involved with the decision making around this. However, I think they're a well-respected professional association, and we're able to move forward independently with the guidelines.
Okay, and I have a quick question. Do you think that the strength of the evidence in a guidelines, like a regular guideline versus rapid guideline, is there any difference in the strength of the evidence? Do you think that because it's rapid, the evidence or the conclusion or the recommendation can be, less, like strength compared to like if we have more time to study all the literature and the articles and the evidence?
I guess there's that there's a potential that could happen. However, I think what you may see more with rapid guidelines is that the evidence is not there yet. And then it's really a decision, how far do you expand your scope, to find maybe indirect evidence. So I think it's quite situational, and I think actually you'll probably see very different situations of it in the subsequent presentations.
Maybe you can chime in here. I mean, I wasn't exactly sure how that question was meant, and I can fully support what Eric is saying, that it's really an issue about the underlying evidence. But I think readers should not interpret just because it was rapid that the designation that was given is somehow different than the designation in a fully fledged guideline or a fully long developed, I mean, a guideline was developed on a regular basis. The idea being that by thinking through that process of a rapid guideline development to not cut corners, that people should be able to trust it the same as a regular guideline.
I see. Okay.
Was that part of that question, maybe?
Yeah, yeah, and I think the point could like goes back is like how much evidence or like how much the evidence will change with time, like for that particular, if like if we're talking about COVID-19, I'm sure there will be
Sure.
more trial coming up, and that may change the whole recommendation probably in the near
Right.
future.
And so then you have to update it. Have to update it regularly.
Okay, all right, all right. Thank you, Dr. Rebecca Morgan. We're gonna move forward, and the next speaker will be Dr. Yevgeny Flaketer. He is a professor at the Department of Medicine at Case Western Research University, at the chief of the Division of Gastroenterology, Louis Stokes VA Medical Center. He has extensive experience working with multiple organizations, including Infectious Disease Society of America for years, and he was the previous chair of the Clinical Guidelines Committee for the American Gastroenterological Association. Dr. Givney, thank you for joining us, and I'll give you the permission to share your slides.
Thank you. Let's see how that works. It still seems grayed out to me.
Yeah, you go ahead.
I think it worked. Oh, no, I apparently have to give. At the Mac, you have to. Let's hope it works. All right, so there's a security setting. All right, let's see now. Okay, I hope that works now.
Yeah, we can see it now. Thank you.
Let's just see whether I put it in presentation mode, whether it flips it. Okay, I have to flip it. Hold it. All right. How about now?
It looks good to me.
Looks good?
Mm-hmm.
All right, well, thanks so much for inviting me. It's a pleasure. I'm totally fine if people want to interrupt me. I know you're recording this, so maybe you want this have a stream, but you know, I think it's always great to ask questions right away. I would like to acknowledge all my colleagues that have worked on this so tirelessly, this was truly a collaborative effort. Why did we do this? I mean, you know, everybody who went through this, right? Just switching on the TV, you got all these people saying something about what to do, right? I'm not gonna say who, but you know, everybody, it seems to be, wanted to say something about it. And obviously, when you have a crisis like that, I can understand people are antsy, they want to find something. In addition to that, there was like a huge number of, you know, I call them experiences that people reported, because sometimes I cannot even call this a trial, but that was all recorded, it was written up, it was sort of all shared, and somehow we felt we really need to try to get a little bit more systematic approaches into this. Lots of preprints, lots of limited peer reviews. So even if a clinician was so astute to be able to read all of that, I think it would have been really hard to filter things out in a way. And so, as you saw with GRADE, I think that's the main advantage, to try to get it into a presentation style that everybody can agree with, and that, I think that's one of the things. Now, this obviously was, I just want to again show who the panel members were. Really very smart people. The chair, Adarsh, I mean, he works here at the Cleveland Clinic. He's super bright, and all the other people, and at the, you know, Amy as a pharmacist was really invaluable in this, and all the great methodologies they've listed here. So we covered also another range of, you know, it's always good to also have other specialties in there. I'm not an infectious disease guy, right? But it's also good to have those people on, and, you know, whether it's hepatology, whether it's nephrology, whether it's critical care and ID, and even, you know, medical microbiology. we had all those people on, which is really important. But everybody gives a little bit of a different perspective into this and thinks through this a little bit in a different way. So this was a great experience from my side. I really learned a lot whenever I sit with these experts, how they look at things, and I can pick their brain. So it was pretty good. So diving right in, I'm not going to talk anything about grade. We already heard this already, how that works. And I'll be more than happy to, again, to go into questions about this. But since I think we really wanted to make this quick, let's run through this quickly and then have a lot of discussion. I think that's where the meat is. So first question that we had, obviously, hydroxychloroquine, right? Touted everywhere, and so we needed to figure this out. So essentially, we're going to show a lot of these evidence profiles. You probably already have seen this. You probably went online, you looked at them. But essentially, what it does is to make sure that you know, we always highlight sort of the outcomes over here. In this case, mortality, clinical progression, clinical improvement, failure of biological clearance, and adverse events. So essentially, just to get back how this all started, right? There was this French group saying, we treated people with hydroxychloroquine and they got all better. And then we looked at it, it was a case series, and many people jumped on that. There was nothing else out there. So people thought, well, maybe it works, because in vitro it sort of had some properties that looked sort of promising. Now, luckily, we didn't have to go that route in the end to look at, in this particular question for just hydroxychloroquine, to look at only the case series. We were able to find 2 randomized controlled trials, and that made a big difference in the end. And both reported on clinical progression, and not really, I mean, there was a difference. You can see it numerically, but in the end of the day, not that much as we had, you know, hoped, and there were no difference in mortality. So clearly they had selected a less sick group. So we couldn't really comment on that either. Interestingly enough, the virological failure was not different, because the whole premise of hydroxychloroquine was there may be a difference in virological clearance. That didn't really pan out. So luckily, these RCTs were there, because otherwise we would have to really scratch our head. Now, it's well known there can be serious adverse effects, and I'll note that the FDA then later on, after we came out with this, also looked into this a little bit more, that we had really serious questions about arrhythmias with that particular drug, QT prolongations, etc. And we'll get to that again a little bit when I come to the combination of hydroxychloroquine with azithromycin. But just to wrap it all up real quick is to say that at the time when we published this, we felt that it's a little bit of a quandary, right? So you have a drug, there could be promise, and now you don't see that. And so we basically said, let's make sure that people, when they use the drug, contribute to science, enroll them in a trial, and the minimum you do is report at least on the series that you do. So we felt there was still a knowledge here. Why did we not recommend against it or something like that? Well, within GRADE, you know, we have choices to make, right? There's some judgments to be made. And one is, do we think that if we say something about not using it, that we could stifle innovation, people wouldn't do studies? And we felt it could potentially be the case. So we rather said, let's not do that at this time. Let's make sure that these trials are completed. Let's make sure that we hear about this, and then go from there. And so we felt that we would rather say, let's recommend that people use it only in the context of a clinical trial. Okay, so from there on, the question came obviously up is, well, if it doesn't really work alone, what about if it's combined with azithromycin? And you know, talking to ID physicians, they feel like that there could be some antiviral property of that particular drug. But here it's even more problematic in the sense that, first off, this was really derived from single arm experiences out of France, and they just added on and added on. And for us, it was particularly difficult to say, what is our comparator then? If we don't have a defined comparator. And you can see over here that we have this little thing here, no azithromycin, no hydroxychloroquine. It says 12 out of 12. So the original study out of France said, well, in those control people that they selected, 12 out of 12 still had the virus at day 6. Now we now know that was probably just a selection problem. And they essentially said, well, all these people, you know, everybody cleared. And then they added more people to it. They, in the end, had 71, and then it was not everyone. It was about 40 people who actually cleared the virus. So we didn't want to really compare it. So there's no relative effect that we are bringing up here, but essentially just showing that the sparseness of the data, the problem with this, they had now some mortality in here with us, but we tried really hard to say, what are the risks? The risks are probably substantial. We at the VA, for example, we had people getting discharged from hospitals where they got the COVID test, they got swabbed, they didn't look that sick, they got discharged from an outside hospital, and they said COVID pending with a script of azithromycin and hydroxychloroquine, right? And if you do that, you're setting them up for very severe adverse events, particularly if you can't monitor the QT. And so we really felt we had to be very careful with any type of these drugs, and we thought that we, again, should only recommend this in the context of a clinical trial to make sure that people understand this is a risky business. There could be serious harm to patients when they do that, and that it was just not ready for prime time. We got a lot of flack for that. There's no question about this, because people felt there was nothing else they could offer. But that is the difference between making something more methodological rigorous and making sure that people understand the limitation of the current evidence, so that they actually also have a choice. If you have, as a clinician, as a frontline clinician, have the choice to also say no, because the pressure was quite large there. Again, interrupt me at any time if you have any questions in regards to those interventions. As you know, there's some additional studies since then. There is the VA study that basically showed that those people who were treated with hydroxychloroquine died more. And people were now saying, we're sort of flipping over saying, we gotta update it right away and say it's dangerous. Well, the same applies when you have single arm trials and you claim effectiveness in a single arm and you have no comparator. You have to be careful if you have a single arm that shows harm. Because we all know that people who come in who are more sick sometimes obviously get more treatment, even if that treatment is unproven. And so you are then enriching this particular group with poor prognosis. And so again, to then say it now is clear it is more harm than good is problematic from a methodological perspective, unless you have comparative effectiveness and can actually say something about that, which we don't have. In addition, obviously, there was a trial out, I think it was Brazil, that looked at high dose versus low dose. So it's, again, not a comparator to doing nothing. In that particular trial, the reason I'm mentioning is that higher dose chloroquine was clearly associated with more toxic effect and clearly not supporting any type of thought that the more you pile on, the better outcomes you might have. All right, moving on. Should lopinavir/ritonavir be used? You know, protease inhibitors, obviously from the day one, was sort of thought to be something that could be tried. It was, again, an in vitro activity. This was an RCT, it was published, fully peer-reviewed, so it was great to have that. It was not a small trial. It had 100 in each arm. If this is anything, you know, highly effective like Hep C, that's all you need, right? Clearly didn't live up to that expectation. There were no difference in mortality whatsoever, because that is really something that we are hoping to see, because in the end of the day, we want to make sure people don't get onto the vent, they don't progress to the stage, and that they can then you can save lives. Because sure, it's not great to have the virus, but in the end of the day, if you survive, then you know it's an inconvenience and you're sick and all sorts of things. But the main issue that we wanted to look at is there a way that you can prevent people to have to be put on the vent? And so for that is obviously mortality is a good measure of that. So that failed, unfortunately. There was somewhat of a better clinical or less failure of clinical improvement at day 14. The problem with that outcome is that it's not well defined. So unless you really take care and blind the trial and make sure that there is really no difference in how we interpret improvement, we don't know this with this trial. We don't know. They could have blinded the adjudication committee. We don't know. We have no report in that saying that they actually did. We had to rate down for imprecision. For risk of bias for that particular issue. And it was also sort of imprecise, as you can see here. So we have very low certainty in that particular effect. And it also goes very close to 1. So there's questions whether that's clinically relevant. So essentially, summing up, lopinavir is not an easy drug to take. I was told, I'm not an ID physician, but Amy Hirsch, who I work with a lot because of Hep C, she's a HIV pharmacist. Apparently that's not easy to take. So in essence, again, very similar to a lot of other interventions, we felt it was not ready for prime time. Although we also thought this is not necessarily a negative trial. It was portrayed as a negative trial because the p-value wasn't reached. The p-value does not mean that it's a negative trial. Look at the wide confidence interval. There is still a chance that potentially some of the protease inhibitor could have some effect. Now, unfortunately, there were some other protease inhibitors that were studied, and they did not show any effect either. So at this point, we don't know whether anything out of the HIV world can potentially have an effect that is clinically relevant in the end. All right, so moving on to steroids. Steroids is a really difficult topic. Presumably, the one thing that investigators wanted to figure out was if the reason that people die from COVID is that there is a cytokine storm, that when at some point, usually after people have been sick for at least 7 days, so it's this kind of late phenomena, we even think that there could be some control of virus already happening, but then for some reason, the immune system sort of revs itself up. There's a cytokine storm. What about if we give them steroids and can abort this kind of process that then leads to ARDS or SIRS and then ARDS and sepsis and intubation and death? And that was extensively done particularly during COVID in China. And we reviewed a lot of trials. And all of these trials did not specifically look at steroids. They were just reporting how they used it. And that created a lot of problem because they were not really geared towards showing a difference. In particular, some of the studies had like a median of 17 interventions that were given, 17 interventions. So essentially the entire kitchen sink. And to then filter out what is the component of steroids in that process was extremely hard. We basically, after we looked at 4 larger trials, essentially gave up. There was no signal. In fact, some of the ways they had looked at the data suggested that there were actually an increase in mortality, an odds ratio of 3, if you looked at the entire hospital stay. We didn't even want to take that because we weren't sure about that harm either. So we eventually just went back and looked at SARS, because in SARS it was a little bit more systematic, and they essentially found out that if you give it early, you could show that actually viral replication may be prolonged. And those indirect data we used to also inform that we felt that there could be actually a chance of harm that we couldn't really exclude at this time. So again, as with many things we do, we felt this was actually potentially even harmful early in the course of the disease, and felt that we needed to give a conditional recommendation against the use of steroids, just to try to hope for an impact on the development of the cytokines, or the prevention of a possible cytokine storm. So the tricky part when we try to parse those studies is that obviously not all the time did we figure out whether it was given early or late in the course in the actual papers about COVID. Now, because there is obviously the other side of the medal, and that's the question: once you develop the ARDS, right? Is there a benefit to this? And here the really tricky part is, because we really don't have direct evidence for COVID, is then to take how much indirect evidence do you take? How much should you use SARS? How much should you use even non-viral reasons for ARDS, community-acquired pneumonia, and so on? We decided to mostly use SARS data on that, and there was maybe some weak signal that there could be a potential advantage to this. We only could summarize it in a narrative format with very low certainty in those estimates or in those effectiveness claims. So then in the end of the day, we decided that we didn't want to go down the route of very indirect evidence. The Society of Critical Care Medicine essentially went further out, taking more indirect evidence into account, and they basically said it could potentially be used. We felt that this was premature and too indirect for this, but this is, again, it's a judgment issue. And Rebecca, feel free to chime in. I know that you have contacts to the Society of Critical Care Medicine, and if you see that I'm saying something that's not completely accurate, please do correct me. So again, in this case, we recommended this in the context of clinical trial. We really felt that this is an important aspect to be studied. Steroids given when somebody is on the ventilator, particularly to see whether at that particular period of time you can prevent death in that critical scenario. Speaking of critical care medicine, tocilizumab, an IL-6 inhibitor, is another one of those things that sort of looked like it had a lot of promise, right? Essentially, this single-arm report saying, well, if we did it, nobody died, right? So the idea being, so this all or nothing kind of concept where when we do that we could show an effect. We had to sort of figure out what is the issue about the comparator, and we tried to figure out just from the text how bad it could have been. We guessed about 20%. So in any event, as you can see very clearly, very limited data, and so we essentially said, although very sort of promising in a sense, right, that at this point we couldn't really say anything definitive. There are trials ongoing. So I know I'm already probably over time, unless Irene waves to me that I need to wrap up really, really quickly. But so I'm just going to say quickly about the other things, which convalescent plasma, a lot of people talking about this. Again, very limited data, single-arm trials, and no real comparator group, despite we trying really hard to figure that out. We said had to be done in a concept of clinical trial. These trials are ongoing. We expect them to come on probably pretty soon. So that's something to look forward to, because there's really good theoretical thinking that this could potentially work, but before that has been established, I think it is premature to do that. Lots of other things have been studied. I don't think I should go into remdesivir. We did not comment on it because at that point we didn't have the preliminary studies, and indeed we don't have the full text of the studies that were reported of having a beneficial effect. So I think it probably would not be good to go into it unless there's questions, then I'll be more than happy to do so. Lots of other things that were looked at. not really something that we can comment on. Most of the stuff just doesn't work. And I can more than happy to comment on non-steroidal and ACEs and ARBs, but at this point, I think I just want to wrap up with the last slide, basically saying that within GRADE, what we really need to say is, what is our confidence in a benefit? What is our confidence in harm? And most importantly, how does that balance between benefit and harm play out? And we were clearly saying that at this point, we do not know whether there's actually any net benefit left over. If we consider those plausible harms that we know, or those drugs that we looked at, we felt that we could not be confident about even a small benefit, and that this knowledge gap is best bridged with making sure that we contribute, making sure that we update this guideline frequently as soon as we think there's evidence out there that could be practice changing. So I'm just going to stop here. Is that okay?
Thank you, Dr. Binge, for your great talk about, like, summary about the latest treatment and evidence on COVID. I think we will take a few questions, and then yes, because
I apologize that I'm over time. It looks like I didn't.
No, that's fine. You're good. But I was like really good. There's a question from one of the audience. He's like saying, what would you say about the argument that, you know, we are in crisis, we don't have time to do like expensive trials, while patients, like, you know, are dying, and we have this pressure from, you know, patients, family, everyone else, that we have to have, you know, use something that at least have some, you know, potential benefit. And it, you know, and like the problem that like doing a clinical trial, especially, you know, small institutions, can be like kind of considered as a luxury, and they can do it. How would you, you know, respond to these arguments, which we really hear a lot, either from a patient or like sometimes from healthcare providers?
Yeah. So our main goal was provide evidence profile and a narrative to understand the evidence profile that lays out the evidence so people can look at it, and if they don't know how to read it, read the text and see the limitation and see how we think about these things. And if at that point they still believe that there is a potential benefit, obviously everybody can use stuff off label, but we wanted to make sure that people understand that, at least from our panel's perspective, that we were not there yet at that point where we could say, well, maybe it's a conditional soft recommendation for something. We weren't there yet. We wanted to make very crystal clear that we at this point do not see any net benefit from all of these interventions having panned out whatsoever. And I see the issue is that people then say, oh, the only time I can use this is in a trial. You know, as long as you report, as long as you're tracking it, as long as you're saying how many people died when you used it, that's a study. So everybody can do that. Everybody can do a retrospective chart analysis and get these data out. I'm totally fine with it. But what I'm not fine is that people just use it indiscriminately and don't follow up. They give prescriptions out and send people out in the field and don't follow up. And that's something that they should not do.
And just to follow up, Rami, on that question, because it's a really important issue, there are interventions or other things in management that are proven to be effective. For example, testing, okay? There are so many states who chose to spend their budget on purchasing, for example, hydroxychloroquine, and not have enough tests available or be able to do contact tracing. So there is an opportunity cost. When people talk about we just have to do something, the problem is we're spending our resources and effort on things that are not proving to have any benefit. And yet we're forgetting that we can be spending the resources on things that we know might help. So I think that is that idea that we have to do something. We have to make sure we don't do harm, and we have to make sure that the opportunity cost is not lost compared to things that will maybe help, even if it's not medication or treatment.
All right. Right. Thank you. Another question is, given how rapid is like literature is expanding with all these observational or like sometimes prospective studies, sometimes trials. For you, like as a member of the IDSA guidelines, how often or like what's the plan? Like how on updating the guidelines? Like is it going to be like another update in a month or so, or like probably later, sooner?
I will have Rebecca answer this if she feels like answering this.
Sure, happy to. So our decision for the management guidelines specifically was that if any evidence became available that would be practice changing, that's when we would initiate an update. So we're working off of the concept of kind of a living guideline in a way. So we're continuously monitoring the evidence. We have a standard search that we run weekly, but then we also do kind of horizon scans for a lot of the preprints throughout the week. So we're just waiting. We're waiting for some evidence to come out to update it.
Right. Great. I think we are in the 1 hour mark. It was like really great talk. After contacting Dr. Reem Mustafa and Dr. Shahinaz Sultan, I think it would be better to split the webinar for today and to kind of like to make another session about prevention and diagnosis in a later date that will be announced very soon. I would like again to thank the panelists, Dr. Rebecca Morgan, Dr. Ing Flakgetter, Dr. Reem Mustafa and Dr. Shahinaz Sultan, although they didn't have the chance to talk today, for joining us with PAMA and give this great talk. We really appreciate your effort, time, and I'm sure like you guys being really busy with all putting all these guidelines together. So as a healthcare provider, thank you so much. I would like hopefully we're gonna meet in the near future again.
Thank you.
Thank you so much.
And
thanks for all the audience who joined us today. We'll announce for the next lecture soon.
Thank you, Rami.
Thanks.
Thank you.